Concerning the first topic, today we start with topography of the upper limb, and as written here with review. So it will not be again the detailed description of the topography, because as you probably remember, we already did it, and you have full text of the first lecture on 29th of October last year, where we completed regional anatomy of the upper limb. Today is just review. So concerning the regions, we know that there are some regions on the upper extremity. This is the anterior view when we see the deltoid region, then axilla, the axillary region, relatively complicated area. Then the anterior brachial region, anterior cubital region, anterior antebrachial region, then anterior region of the wrist, and or carpal region, and also the palmar manus or the palmar region. The back side shows the relatively large area, the deltoid, then again large area, the scapular, and then the same areas from the dorsal side, that means the brachial, posterior, cubital, posterior, antebrachial, posterior, carpal, posterior, and also dorsomanus. So concerning the regions, we will not specify the same as we did in winter term. That means we will not describe all in detail the branch or the areas or better the boundaries of each region, just quickly. So we have to start with the first region. This is the scapula. This is the biggest in the area around the shoulder. So the title would be the scapular region, and the scapular region in fact comprises the area over scapula. So we can just say that this is just the over scapula dorsally, and as usually we have to say some words to the palpable structures. We call it the landmarks. So what is typical for the scapular region? Number one, what we can palpate is definitely the spine of scapula dorsally, which is in fact palpable in the whole extent. Then superior and also inferior angulus, more superior, less inferior, because it's more covered by the muscles. Then also acromion, the most lateral structure found on the scapula. Concerning the structures found in the region, so we would start with the first. We have more diagrams, definitely. First view, we see the posterior view of the scapular region, just for better orientation. Here we have superior angulus, inferior angle, then the medial border, medial margin. Then we see the spina of scapula with acromion. Here is the greater tubercle of the head of humerus, and then the neck and also the shaft of humerus. Concerning the muscles, this is supraspinate, attachment is here, infraspinatus here, then teres minor, these three, plus from the ventral side, the subscapularis are four muscles. We call them muscles which are rotator cuff. And then finally we see also teres major, and then on the dorsal side you see the caput longum of triceps, caput lateral, medial is not seen. This diagram shows not only the scapular region, but also, as you see, the position of the radial nerve and profunda brachii, deep brachial artery. And here we see axillaris, the biggest nerve in this area, and also circumflexa humeri posterior, which is in fact attached to the to its sister, which runs on the anterior side. So this is the first view. And before we start with the text, I have another one where we see the after removal of the central position as parts of the muscles, we see again the same situation, but also with the vessels. So please pay attention to the foramina. We will start with foramina through which pass the nerves and nerve and vessels. So here the foramen quadrilaterum or quadrangular foramen or humerotricipital foramen, there are some synonyms. We see the axillary nerve, and together with the nerve runs the circumflexa humeri posterior. And the second, again, the boundaries are as follows. This is caput longum of triceps, then humerus definitely, and then teres minor, inferiorly caudally, not caudally, in fact, distally caudally is the teres major. No, and in the triangular foramen, the only one structure, circumflexa scapulae, passes from ventral to dorsal side, and this artery forms the network together with the arteries like dorsal scapulae and suprascapular, etc. So the artery plus also intercostal branches forms the collateral system. We call it rete articulare, so articular network. So we would start with this diagram. So first of all, concerning the skin and so on, we will not pay that much attention, but important are the foramina. So the just very simple sketch to show the foramina of this area. We can just again very simple sketch, and like that maybe it would be more than sufficient, and also the acromion and spina and so on, sufficient, definitely sufficient. And here would be the muscles. I'm just sketching the muscles because they are attached on the humerus, rotator cuff, and here we have the humerus, then the teres major, and also long head of humerus. That's all. So concerning the muscles, fine. No, and now what we see. So here's the scapula. It deserves to color a little bit the bony parts, while and also logically the humerus. And then look at the attachments of these muscles and just placing the area. The number 4 is not here. This is subscapularis, and if we see also the muscular bellies. So here we have supraspinatus, infraspinatus, the second one. Then teres minor, definitely teres minor, and here is the teres major plus, logically, long head of tricep, sorry, and here is the this teres minor, teres major. That's it, sufficient. No, and then using black for the nerves. Here we see the first one. This is the nerve which is called the axillary. We remember, and also here we have the posterior circumflex artery, which is attached to anterior. These two, and here runs the artery which is called circumflexa scapula, and I'm just sketching some arteries which run also from the other side, so they form the network. This is just a sketch. No, concerning the names, here we have foramina. The first one is the we call it quadrangular foramen, quadrangular foramen, which contains the axillary nerve. Maybe that the foramen could be like that. And so this is the axillary nerve. We know that axillary nerve innervates deltoid. We can also add deltoid, how the deltoid covers the area. It's attached to the deltoid tuberosity. So axillary nerve, and then posterior circumflex artery. In each diagram, we will not describe only the structures, but also we have to say some words which are of clinical importance. So these structures are quite clear. Here, this is another foramen. Maybe that we can help to see the foramen, maybe using another color blue. Doesn't matter. This is the triangular. So we call this second foramen, we call it triangular foramen. And this foramen contains the circumflexa scapulae artery. Good. No, and here we can just add the information that these are the anastomoses interconnecting the arteries around the whole scapula, and also, of course, logically around the shoulder joint. And these arteries provide the very important collateral circulation, which is important not only in the surgery approach, in any blockage of the axillary artery, for instance, so then the anastomosing arteries supply this flow. And as we said, here we have attachments of these are attachments of the muscles, and these muscles are well known as the system, as the complex of the rotator cuff, which are supraspinatus, infraspinatus. We can name them in the next diagram. So I mean that this could be sufficient information. We will repeat the rotator cuff in the next text. So the second region is the deltoid region. We said that the deltoid muscle is a large muscle, relatively strong, covered by the fascia. Again, this region is over the deltoid muscle, and we remember that in this region is relatively thick skin. If we will dissect it, so we see thick skin. Then fascia is also relatively thick and forms the septa. The septa pass into the muscle. So in fact, the septa form smaller spaces which contain the complex of the fasciculi, and that complex forms in fact relatively strong muscle. No, what else? When we look in the skin, there are also the superficial nerves. Sometimes we have to mention also important supra. So we will name the supraclavicular nerves. We probably remember that they come from the cervical plexus and then pass over the superior part of the area. No. Very important are bursae. We know that bursae are the pouch-like structures, cavities, which contain the fluid, and there are two which are of high clinical importance. Number one is the subacromial. We will draw diagram, subacromial, and the second one is subdeltoid. These bursae are important for the movements, for stability of the muscle, but on the other hand, they can calcify. So we could add, there are some clinical points. First of all, the calcification. That means this is the accumulation of the calcium, salts of calcium, and producing strong pain, very complicated situation for the patient, and also limited movements. strongly limited movements of the shoulder. This is number one. Sometimes we call the situation the frozen shoulder, and also the next negative point is the infection called bursitis. Bursitis again connected with the pain. Concerning the classification, the only one way is the surgical. I would just say surgery, so that means cutting the muscle, removing the bursa, and also clean the space, or also completely remove. So this is the first point, first part. Concerning the rotator cuff, it must be mentioned that this complex of the muscles, so I mean that is sufficient. The next point would be the rotator cuff. We said that there are four muscles. So I just would repeat them. And this is supra, and infra spinatus. Sorry, my mistake. I have to also check the screen. Infra spinatus, then teres minor muscle, and also the subscapular. There are four muscles, and these muscles are important for the I would say not only movements but also stability of shoulder. This is very important. Shoulder stability, movements definitely, but also negative point is that the infection, or in fact any type of inflammation also, not only the calcification of bursae but also inflammation of the tendons of these muscles of the tendons may cause, or is really a common cause of shoulder pain. Yes. So rotator cuff, very important group of the muscles. Concerning the deltoid area, I mean that this is definitely all bursae, rotator cuff. This is sufficient. We are starting with the third region, which is the axillary. So axillary region, or axilla, maybe that is better to say axillary region. Axillary region represents complicated area for dissection. So axillary region is bounded, maybe that here, because it's very important area, it's not bad to define also the boundary, which is very easy. Boundaries are in fact four boundaries. When we look at I will draw very simplified drawing. Boundaries are in fact anterior, posteriorly is the pectoralis major muscle, then posteriorly latissimus dorsi muscle plus, and teres major, then wall of thorax, definitely, so that means ribs, and plus serratus anterior muscle, and laterally humerus plus muscles attached to the humerus. So we could say that pectoralis major is anteriorly, latissimus dorsi posteriorly, then wall of thorax medially, and humerus laterally. No, I mean that is more than sufficient. We know that when we look at the whole region, this is like the conical space. The tip lies at the level of first rib, and also we could say first rib, yes, and first rib or tip oriented towards the thorax. Concerning the contents, we have to say that first of all, in subcutis, we could see because skin is relatively thin, we can see the superficial nerves, number one, and we would name the most important one, intercostobrachialis. Brachialis, as the name says, that the nerve passes from the intercostal spaces, is attached or joins also the fibers of the brachial plexus, sensory nerve. Then follows the fascia axillaris, axillary fascia, and it lies, and under the fascia, we would say under the fascia, we could see, dissect and define the lymph nodes. We call them axillary lymph nodes. These lymph nodes we will only name now because in the chapter review of topography of the trunk of the thorax, we will speak about them again. The lymph nodes are or form the groups, which is when we have A, for instance, we start with humeral group. Humeral is in fact lateral group. Then B is interpectoral. Name says that the lymph nodes are situated between the pectoral muscles, interpectoral. C is the pectoral. Again, pectoral means that they are situated anteriorly, so we can say anterior group. Then CD is the subscapular. Subscapular is posterior group. DE is central. Also sometimes mentioned apical, or sometimes central and apical are divided. The lymph nodes group, we would say A, then A and E, they run along the axillary vein. Concerning the clinical importance of the group of all the lymph nodes, they are important for the surgery removal. That means removal of those which are affected by carcinoma originating from the mammary gland, from mama, and maybe that we can draw now the horizontal section, which shows in fact all the important points of the region. Very simplified diagram. So looking first of all at the maybe that it could be the best one when we see the humerus. This is the head of humerus, then scapula forming the joint. This is the scapula. On the dorsal side and ventral side we have the muscles. Attachments are not seen because they are at the different level. The bones definitely colored in typical color, yellowish. And then we need what? We need also serratus anterior, which is attached to the medial margin of the scapula. Then first rib, just to see the position of the thorax, must be also colored by yellow. No, and then what else? Then the head of, or better, close to that lies the long head of triceps. Then the deltoid muscle, deltoideus, that covers all the area. We see the big muscle, plus pectoralis pectoralis major anteriorly, pectoralis minor posteriorly. No, And then very important, the neurovascular bundle. I'm drawing more space here, is not that big, definitely not, in which we see at the center lies the axillary artery, medially, anteriorly lies the vein, accompanying vein, and around run or descend 3 fasciculi of the brachial plexus, coloring the muscles just to see their position. This could be also yellow because of the tendon, but I mean that this is sufficient, plus the muscles, their names and position. Of course, everything is covered by the subcutaneous skin, etc., etc. No need to add more. So in the key position, deltoid laterally, the humerus, no need. This is the long head of biceps. Also there is a triceps. Short head will be seen, but doesn't matter. This is sufficient. Deltoid, pectoralis, pectoral muscles, major, minor, serratus anterior, first rib, definitely, first rib. Then I'm adding also one important nerve, which is the long thoracic or thoracicus longus, long thoracic. Then the subscapularis. That one is the supra. We are in lower positions. Infraspinatus, infraspinatus muscle. That's it. Plus neurovascular bundle, which is situated here, artery, vein, nerve, or 2 veins, and these are subscapular. These are scapular nerve plus artery plus vein or veins. No, and if we speak about the important bursae, so one of them, that one is larger, wider, This is the subdeltoid bursa. Subdeltoid bursa. That's it. So all the structures are quite clear, are well seen. What we see at the center is the circular connective tissue forming the coat for the axillary artery plus vein and brachial plus brachial plexus. These are 3 fasciculi. Brachial plexus. We remember that brachial plexus consists of the supraclavicular, infraclavicular portion. So 3 fascicula form 5 nerves, mixed nerve, and 2 pure sensory. Concerning the position of the artery, which lies at the center, and vein. So we already mentioned one, more or less, we can call it rule, in which it's written that when we look at the extremities, so in close proximity to the thorax, to the wall, or to the thorax, the artery is accompanied by 1 vein only. In the distal portions, like in the antebrachium, we can name the radial artery and 2 radial veins, 1 ulnar artery, 2 ulnar veins. So then in the peripheral areas, always the artery is accompanied by paired veins. So there are 2 veins. The reason is the pulsation. We know it, we remember. So this is the horizontal section. I mean that everything important is here. We know the boundary, we know the structures, we know the contents. Some important information. So what is important? Number 1, important and relatively clear are the relations between the arterial between artery and vein. This is what I said now, that the artery is at the center. So we see it from the drawing. Then in the subcutis, we have to mention also the vein. We call it thoracoepigastric vein. When we look at any atlas, thoracoepigastric vein, so we could say that the vein has interconnections with the veins of the anterior abdominal wall. So maybe that we can add this arrow and double arrow and say that it has connections with the veins of the anterior abdominal wall. This is always important, that these interconnections play an important role in the return of the blood from the wall of abdomen above the umbilicus into the regional veins in the axilla. The same would be with the lymphatic drainage. What else? Clinically important are also, I would just say, in clinics or clinically, just clinical note, or so we could say clinical note or clinical oriented notes. Number one is the fact that surgical removal of the lymph nodes. We said of the lymph nodes of axilla or axillary lymph nodes is necessary to, we would say, necessary is to consider the position of the intercostobrachial nerve. This is the nerve, what we said, from second intercostal. It appears in the second intercostal space, and this nerve innervates, because it's sensory, I would just put sensory. So it's necessary to consider the position, because any damage, so we would say damage to the cutting it, or damage, any damage to the nerve leads to the paresthesia. So the patients lose number one, pain, or lose also the sensation of the brachial paresthesia of brachial region, of upper, maybe better is to say of upper brachial area or region. So this is one important point. Number two is the fact that the same is with the thoracodorsal nerve. So maybe that we can do the same, that the same situation is not only connected with the intercostobrachial, but also another nerve is a thoracodorsal. Thoracodorsal nerve, we remember, is a strong nerve innervating latissimus dorsi muscle, the biggest muscle in this area. And the same, I would say, damage of the nerve or any effect to the nerve leads to the paresthesia, and also limited, very important, are limited movements of the shoulder, of latissimus. So we would say of the shoulder, because latissimus lies on the dorsal side, is important for the movements at the shoulder joint. And also we have to mention one more nerve, this is the thoracicus longus. We said that long thoracic nerve is the nerve which lies on the lateral surface of the serratus anterior muscle, covered by just the fascia of its own muscle. And thoracicus longus nerve, I would add, also innervates the anterior serratus anterior muscle, which is attached to the medial angle of scapula, attaching scapula to the wall of the thorax, and any damage, we will speak about the damage again in the lower part of the thorax, but also we have to mention that it leads to the scapula alata. Ala, scapula alata. Ala is the wing. So that means that, and maybe that the best would be another diagram, practically the same what we have published now, with one exception. There is cephalic vein, I have to add. This thoracicus longus nerve lies practically at the center of the whole course, on the lateral side of the muscle, and you see that is attached on the medial angle of scapula. So scapula is not attached anymore after damage to the nerve to the wall of the thorax, and instead this position moves dorsally. It's like the wing of the angel. That's why it's called scapula alata. Scapula alata. So when we look, so please back to our drawing, we have to add one more structure, and this is the cephalic vein. So note that here is the cephalic vein. We will speak about the cephalic vein several times, because the cephalic vein is the typical superficial vein. It passes in the sulcus. So in fact, we see here the sulcus, the groove, and this is covered by the fascia. Definitely, everything is covered by the fascia, but the groove is called deltoidopectoral groove. So I will mention it again. So thoracicus longus, scapula alata. Very important topographical, very important structures. And the last point, just to know that there is the, we call it deltoideo pectoral groove, sulcus, and it contains the cephalic vein. We will speak about the cephalic vein as the typical vein collecting blood from the superficial layers of the upper extremity, and also plus the thoracoacromial artery, and this artery supplies this area muscles around, and also the shoulder joint. So this is the next area. Then follows the area called brachial. We call it brachial region, regio brachialis. Brachial region is the area, is the region which in fact descends from practically is the large dorsal and ventral area. Brachialis is divided into the anterior and posterior region. Brachial region, maybe that the best would be, instead long discussion, to show you one section. We remember that section, so just sketching with humerus at the center. Then the fascia, brachial fascia, fascia brachialis, the fascia brachialis. I can name it brachial fascia. So, and also we know that to the humerus, this fascia sends two septa situated medially and laterally. So we see the septa. We can name just one. This is this one when we look at the either in proximal distal direction on the right side, or distal proximal on the left side. So in our drawing, this is the lateral. The full name is lateral, would be lateral intermuscular septum, lateral intermuscular septum, and this septum plus the medial one divides the whole space into two principal we call it osteofascial facial spaces, or better compartments. Compartments, and the compartment is anterior. We can use A, and posterior, anterior and posterior. Compartment anterior, in fact, contains the flexors at the joint. This is the biceps brachialis, and the posterior compartment contains the extensors, the same joint. Important for us is the position of the superficial structures. So, like the superficial large vein is the cephalic. Again, we see the cephalic vein, and in close proximity to the medial septum, in proximal part, medially, or also in the subcutis. So I will draw it here. Is the basilic, vein, its sister, in fact. And then we are looking also at the nerves. So anteriorly, medially, anteriorly will be the superficial branches. All of them, in principle, on the medial side around the medial cutaneous brachymedialis. So we could say that these are the superficial cutaneous nerves from the brachial plexus. At the center, between the flexors, is situated relatively large nerve, although it supplies the skin and also the muscles of the anterior compartment, which is called musculocutaneous. Musculocutaneous, you know it. Cutaneous, you know it definitely. Musculocutaneous nerve. Then posteriorly, close to humerus, lies the radial nerve and vein profunda brachii. We will see the diagram. And this nerve forms a sulcus on the dorsolateral side of the humerus. So we call it sulcus nervi ulnaris. Radialis, radial nerve plus profunda brachii artery plus veins, the same as we said. No, and biggest accumulation of the structures found in the medial side, close to the or in front of the medial septum, is the first of all medial nerve is here. Then the brachial artery. We are on the brachium with two veins, accompanied by two veins, and also ulnar nerve. Ulnar nerve is situated on the septum, and then it moves dorsally. I'm just drawing the arrow. So what we can do, we can use different color, maybe this one, and describe all the structures together. I would say ulnar, because we see that ulnar nerve moves ventrally. We know where. No, definitely close to the medial epicondyles. Then, so we could say that this is the medial nerve. Medial nerve, nervus medianus, medial nerve, big nerve of the brachial plexus, plus brachial artery plus veins, and then ulnar nerve. Concerning the so all these are the structures found in the brachial region. We describe two regions: anterior brachial region. We see that compartment is better, compartment. The septa divide the whole area into two compartments, we said. So then anterior, so just some words to the anterior compartment. First of all, what we have in subcutis, when we dissect it, so then in subcutis we could see the superficial veins. Superficial veins, we said basilic. No, it's not bad to know that basilic vein opens into the brachial vein, and the second one is cephalic vein, and it opens into the axillary vein. So they have different and superficial vein, basilic, cephalic. Good. Then in this compartment, I forgot to put number 4, brachial region, and we could add 4A. Concerning the position of the other structures, so the superficial veins, superficial nerves. No, we said mainly from the this is the sensory cutaneous nervus cutaneous brachymedialis or medial cutaneous and brachial nerve. Sufficient. Then what we have to see is the brachial artery plus veins. Brachial artery is situated in the mid of the region, lies in front of humerus, and we can, in case of bleeding, we can comprise. So I would add in case of bleeding from this large artery, compression. You can add compression. There are more arrows, but it's faster than written. The whole sentence is compression of the artery against the humerus. Good. Important information. Bleeding. Very important are the situation concerning the fractures of humerus. We could say that fractures of humerus are many times. Important traumatology, definitely important for traumatology, important for orthopedic surgeons, but it's not bad to just quickly revise the fractures of the humerus. I'm just sketching the head of humerus, greater trochanter, bone shaft of humerus. Maybe that would be sufficient, that you see the lateral and medial epicondyle. So this is the medial epicondyle, like that, okay, and then here we have the typical trochlea. I'm cutting it here because otherwise the shaft must be longer. No, and using blue or any other color lines, we could say that very frequent are fractures of the proximal end in the surgical neck. We know that all the fractures can affect the vessels. Then in proximal, and also the fracture of the tuberosities. That means here following the anatomical neck, but also the greater trochanter, even lesser trochanter, not trochanter, tubercle. So we would say these are tubercles, and here we could say that we are. We can add also arrow, and also at this level arrow. So these are in the proximal end the tuberosities. Tuberosities could be fractured. Then in the shaft, we could say shaft or diaphysis. There are many types. Typical if I will draw the radial nerve, you see it passes like that and appears here. So the radial nerve is good example, and also most common place is the fracture at the center. So for instance here, so this is the shaft, we are at the level of the bone shaft. No, and also we can draw, this is the radial nerve and also ulnar nerve, which descends here and then follows. So we could say ulnar nerve. So then the fractures and can affect, so in this level, or even the fractures of the epicondyle. So we could add that this is the medial epicondyle. So also the fracture of the epicondyle anteriorly, posteriorly, then we will see on the same on the ulna. So is the ulna also, because ulna is the place of attachment of the triceps. So this diagram very simply shows the situation of the fractures of humerus, and we could summarize that the fractures of humerus at different levels can affect the compression of nerves. Good example is the radial nerve or ulnar nerve, of nerves and arteries, because this is not only the main artery, but also, as you see, profunda brachii. We could add profunda brachii, deep. We call it also deep brachial artery. No, I mean that this is more than clear. This was the A, and then the same would be the B, and the area B is the posterior compartment, or even better, posterior brachial region. No, posterior brachial region contains in the subcutis superficial nerves from radial nerve. So we would say that skin is thicker, and if we dissect, so then in subcutis they are superficial sensory cutaneous nerves from radial nerve. That means posterior cutaneous brachii posterior. Then of course then fascia, and then follow the extensors. That means practically only triceps brachii with 3 heads, but also anconeus, much smaller synergist. We remember that these two structures, which run, as we said, in the dorsal side, could be affected by the fractures of the bone shaft. So extensors and then profunda brachii, as we said, plus radial nerve on the dorsal side. No, important would be the collateral branches. We will speak about them when we will speak about the cubital region, cubital fossa. But just very quickly, collateral branches of the arteries, they form the articular network. That means rete articulare, pure Latin word. Is not bad to revise Latin. Repetitio est mater studiorum. Around the elbow joint. Yes, important collateral system. The same as around the scapula. But the collateral arteries, collateral branches, they originate from the main artery, brachial, and also its branch, the deep brachial. But we will see them, we will speak about that in the following region, and the following region is the cubital region, is the cubital region, cubital fossa also, called cubital fossa, fossa cubitalis, fossa cubiti, and we know that the boundaries are more or less artificial, so one could be explained here. We see that the region here is in orange, lies 3 fingers above and 3 fingers below the line. This line passes, in fact, through the epicondyles, or better to say through epicondyles of humerus. Good. We divide the cubital region into 2 compartments. I would repeat, 2 compartments, also artificial boundaries, but I'm sure that is sufficient. Anterior cubital compartment. Region is better, region. And first of all, in subcutis, cutis skin is very, very thin, because they are thin, and we are also wrinkles. Yes, subcutis is also relatively thin, and in subcutis we see the superficial veins. We have to draw a diagram on the next page, and this superficial veins are well known, basilic, cephalic. We also remember that basilic, cephalic are the veins which represent the places of the intravenous injections. So here we have, this was brachial compartment, this was for B, and then it must be number 5. Good. So when we look at number 5, cubital region, we remember that there are 2 main veins. This is cephalic. One could be cephalic, anyone. Cephalic, basilic cephalic vein, basilic vein. They are interconnected by very variable vein called the vena mediana cubiti, which is attached to the vena mediana antebrachii. So vena mediana or median antebrachia, vena mediana antebrachii. This one is the vena mediana, median cubital vein, either Latin or English version, doesn't matter. Median cubital, vena mediana cubital vein. This vein is important because this vein represents important interconnection with, because it's superficial, with deep veins, with the deep cubital veins. Which ones? No, we are in cubital region, so that means that it must be the brachial vein or its branches. And I would add a red or orange arrow. This is that interconnection with the deep veins. We call it a Graves vein. It's Graves vein. Important is fact that it's valveless. Doesn't contain any valves. That means that it permits the flow of blood in both directions. Used, I would say, these veins are used for intravenous intravenous injections, intravenous injections. Then the Graf's vein is used in surgery for the intra or arteriovenous connections. They need connections between arteries and veins, so this is use this Graf's vein. No, so this is the anterior cubital region. So we see the veins, that one, and so on. There are also two lymph nodes, two small but important lymph nodes, which are situated close to the basilic in this place. These lymph nodes, I'm drawing just two dots, close to basilic vein, and we call them supratrochlear lymph nodes. Supratrochlear lymph nodes, maybe green would be good, and they become enlarged, become infected. I would just put infected by inflammation or inflammatory process, inflammation of flexor tendons. We know that flexors or also extensors are covered, the tendons are covered close to the carpal region and hand. I would say flexor tendons with the synovial sheath. So this infection of these tendons usually affects the supratrochlear. Then we can palpate bigger lymph nodes. No, and there is another practical aspect. So clinically important points could be in green. And this will be important relations between bursae. Maybe that better would be to place here posterior, yes, cubital region, because we are describing anterior posterior. So I haven't mentioned. I have mentioned anterior. Sorry. This was, I just forgot to place 5A and then 5B, because everything must be in order. This is called posterior cubital area, cubital region, that's it. And this posterior cubital region contains, in fact, the end of humerus and then also olecranon of ulna. So important for us would be bursae, and these bursae are, in fact, there are more, but one is very important. This is bursa subcutanea. So bursa, I would use the whole official name, bursa subcutaneous of olecranon, and there is also the upper bursa subcutaneous frequently affected. I cannot either compression, etc., trauma, the infection or inflammation, inflammation also leading to bursitis. Again, bursitis is painful situation. Another important point is the position course of the ulnar nerve. We know that ulnar nerve descends from the brachial region into the cubital. This nerve could be compressed by the situation in the groove. So we can touch it, or we can describe the infection or any compression. So maybe that I would say compression of the nerve in groove, in sulcus, ulnar sulcus behind the median epicondyle, leading to paresthesia of the nerve. We know it, that we feel it as a typical irritation, mainly on the medial side of the palm, and also affecting the fourth and fifth finger. Good in groove of humerus, definitely. And the last point, common site of the fractures in this area is the olecranon. So we could say fractures of olecranon, fractures of olecranon, repeating frequent commonplace frequent fracture, leading to the dislocation of fragments, because sometimes the olecranon is destroyed divided into fragments, and because triceps is attached, so then dislocation is typical. Dislocation because of the triceps brachii. Triceps brachii. Yes, triceps brachii. And there is the only way, and this means surgical approach. I would say surgery. We call it osteosynthesis. No, that's it. Posterior cubital compartment. We have to mention one more topic, and these are the syndromes or symptoms, palsies. The palsy of the main nerves. We know that all the nerves descend on both sides, with the exception of the axillary, because it lies in the area of the deltoid region. But median palsy, median nerve injury in elbow joint, cubital tunnel, and then pronator syndrome. So we could say that there are typical syndromes in cubitus, and also in the lower part, in the antebrachium, but we will say some words to each. So first of all is the median nerve injury. Median nerve injury is the situation when the median nerve in the elbow joint, in the area in the fractures, so in the elbow joint, could be affected as the other nerves, and we know that the nerve, the leading to paralysis of the ulnar nerve, and ulnar and median nerve. That means. So it could be at the elbow, but also at the wrist. So just on sides, we could say that in median nerve injury can be seen in the or at the elbow. We will speak about that now. Then at the wrist, later wrist, which means carpal tunnel. tunnel. This is typical syndrome. So medial nerve injury is typical situation if the nerve is compressed, and it seems that because it innervates, medial nerve innervates the thenar, and also the deep muscles, with the exception of deep head of flexor pollicis longus and adductor, which are innervated by on a nerve. And so then usually the second and the third fingers remain partially extended. We know if we can flex, so then we know that also the flexors are innervated by this nerve, and if there is a flexion, so the second and third remain fully or partially extended. It seems that this is narrow hand. It seems to be like an ape hand, or this is or ape-like hand. So maybe that we could at arrow say that this is like the ape-like hand, and also we call it as the hand of papal benediction, because it's like the benediction, right? Hand of papal benediction. We will speak about that again, but we have to mention this situation right now. One thing, this is medial nerve. Second one is the cubital tunnel. So next point, called cubital tunnel. Quickly again, we don't need any details at the moment. Syndrome. Cubital tunnel. No, cubital tunnel means that there is another nerve. We know that the cubital tunnel is the very simply, I will show you also diagrams. The tunnel is formed by the connective tissue, by the tendinous tissue of heads of attachment of flexor carpi of flexor carpi ulnaris. We are on the ulnar side. I will show you immediately some figures. So the arch is placed for the ulnar nerve. We could say that ulnar nerve maybe not frequently, but maybe compressed. We know that it could be compressed also distally. So the ulnar nerve can be compressed either at the elbow or at the wrist. Could be compressed in this tunnel, and it leads to the symptoms. We would say symptoms are the same as the palsy, as the lesion or palsy. Both words are correct. As the lesion in the sulcus nervi ulnaris. We know that the sulcus nervi ulnaris lies behind the humeral or medial humeral epicondyle, medial epicondyle. And we know the symptoms because if the ulnar nerve is compressed, the hypotenar is not under control, then the deep then the lumbricals are affected, and also it results in typical view when we see the hand. So the hand is like a claw, right? You see, it has like a claw. That's why we call it claw hand. Claw hand. No, fine. And the last one, because we have to mention all of them, is the pronator syndrome. And pronator syndrome is the situation if or when again the median nerve, so we would say compression of median nerve, of the median nerve, compression of the median nerve. And this compression could be seen between the heads, because there are two heads, of the pronator teres muscle. No, teres muscle. It could be caused by trauma, usually trauma, hypertrophy of tissue, of fibrous tissue, etc., edema. So this as usually, and it leads to the paresthesis, paresthesis of median, the same ape-like median nerve, ape-like hand. This is absolutely sufficient. So this was the area number 5B, although this is the anteriorly, but it doesn't matter, just to know that there are some symptoms. We start with the next region. This is antebrachial, 5-6, antebrachium, leaving cubitus, antebrachium. Before that, I have to show you some diagrams, because I have to show you where all the important areas back to the position of the radial nerve. So here could be compressed together with artery, or destroyed, even destroyed by the compression of the fragments in the situation when the humerus is fractured. Then it passes through the septum intermuscular, the lateral septum intermuscular. Here could be also compressed, but then descends. This is the radial nerve. Here we see the cutaneous antebrachial posterior. So we said that posterior area is innervated by the branches. Then we said that we already explained the region of the brachiums, antebrachium. This is what we practically did. Muscocutaneous, median, ulnar, without vessels, because the vessels run together with the nerve in the distal fourth of the antebrachium, superficial nerves, position of the radial nerve profunda, brachii, and the veins, accompanying veins. Here we have the radial, this was already mentioned, radial nerve. Here we start with the antebrachium, why not? So this is one diagram typical for antebrachium in the situation when we cut the skin either in median plane or more on medial side, doesn't matter. In dissection we are opening the whole region, and on the fascia, on the antebrachial fascia, that means suprafacial space, subcutaneous. In subcutaneous structures are the superficial veins, as we said several times, the cephalic and basilic, mediana cubiti and mediana antebrachii, very variable vessels, and they run together with the superficial nerves. So this is the superficial view, and then I have here also that antebrachium region, the antebrachial region anterior. So this is what we will use right now, just for summary. Here we have the ulnar nerve. This is the medial nerve. Here we see the musculocutaneous, then bisect brachii with the aponeurotic attachment and with the deep attachment to tuberostas radii. We don't see both branches. This is just the radial because the ulnar runs medially. Then we see the group of the muscles with the common origin on the medial epicondyle. Here is the pronator teres. We see just one head. And the long muscles, like we will describe in the following minutes, also the palmaris longus, and then flexors, and then flexor carpi ulnaris. We said that flexor carpi ulnaris is the muscle which has also two heads. The tendinous tissue or connective tissue contains, or through the tissue passes, the ulnar nerve. We don't see the course now because it passes relatively deep, and then it can compress. So we speak about a cubital tunnel syndrome. Then, as we said, in the distal end or distal fourth, the ulnar nerve joins the artery and they run together. When the ulnar nerve is more medial, ulnar artery is more lateral. They run over the flexor retinaculum, so that's superficial, and they run and enter the canal. We call it canalis nervi ulnaris or Guyon's canal. We will speak about that. On the lateral side, we see the radial artery. The radial artery doesn't enter into the canal because the canal covered by retinaculum flexum is called carpal tunnel. So it runs laterally. No, I mean that it's very, very clear. And one more diagram, that one, we said that there are some collateral systems. Details are not necessary. We mentioned that the arteries that descend brachial and profunda brachii, they send the collateral arteries, branches, and then the branches of the brachial artery, the ulnar and radial, give off the recurrence. So all the vessels or the arteries together for the collateral system. So I mean that we start now with the regio antebrachialis. We call it antebrachial region, regio antebrachialis. The regio antebrachialis is the area which descends from that lower boundary of the from this is cubitus, and then it extends up to the styloid process. That's it, styloid process of radius. Antebrachial region is also divided into anterior posterior. Maybe that very simple sketch would be the best. We remember that in this oval field, here we see the antebrachial fascia antebrachii. In subcutis, we see the sensory branches. So these are sensory, we could say cutaneous nerves, cutaneous of antebrachium, direct branches of the brachial plexus, dorsally, posteriorly, cutaneous nerves of the radial nerve, mainly radial nerve. Only laterally is also musculocutaneous. But we start with the position of ulna. Is attached to the fascia. On the other side, drawing. I would just put ulna. That's it. And in subcutis, note please that we have to repeat the position of cephalic and basilic. Yes, so basilic on the medial side, basilic vein and cephalic several times described cephalic vein. That's it. Don't forget the position of the interosseous membrane. We know everything, and plus 2 septa, which form together with the fascia and divide the whole space into 3 compartments, which is anterior, posterior, and lateral. So anterior, posterior, lateral, and we just say this. These are 3 osteophyseal spaces or compartments. That's it. Important for us would be the position of the main arteries and nerves, anterior, posterior, and lateral. We know that anteriorly are mainly flexors arranged into 4 layers, dorsally 2 layers only. When we look at the position of the main nerves, so we start with the first one. This is the median big nerve, but without any, just very small artery accompanying it. So then just median nerve running like solitaire. Then on the ulnar side, we have the ulnar nerve. So please, ulnar nerve must be medially. Ulnar artery must be more laterally, the same in the carpal region. And of course, as we said, in the periphery, the artery is accompanied by two veins. I don't have place, so I would add arrow in light violet, and we can place U, because this is everything ulnar. So here we have the ulnar nerve plus artery plus 2 veins, median nerve, ulnar, done. On the lateral side, we have radial nerve, but also radial artery and 2 radial veins. This is very clear, so we just add that this is the radial artery plus veins plus superficial branch of radial nerve. Because we can ask, where's the deep branch? Deep branch is here, situated close to the posterior septum. We can add posterior septum. Of course, the full name is the, again, posterior intermuscular septum, but this is sufficient. So you can label it just, this is the deep branch, profound deep branch of radial nerve. No, and there are also 2 groups of the nerves, small nerves from the radial, but from the ulnar artery plus veins. We call them interosseous veins, artery veins. That's it. So 2 arrows, maybe that all together would be yes, here and there, and we can put EIN. IN means interosseous, anterior plus posterior, interosseous, artery plus veins plus nerves. We said that nerves come from radial. So I mean that it could be all to the distribution and position of the main structures. 6A would be anterior, briefly anterior compartment or anterior region with the anterior compartment. Lateral is usually described together with the posterior. Anterior compartment, skin, we said skin plus superficial plus cutaneous nerves, we said. Then fascia, follows fascia in the dissection, then follow the skin plus superficial veins, then fascia, and then 4 layers of muscles. 4 layers of muscles in 3 groups, and we can name one is very specific. This is pronator quadratus, pronator quadratus. Maybe that is not bad to say the pronator quadratus. We know it's pronator teres, pronator quadratus is the it's like that. You see, runs transversally and then above that run the tendons, and we say this is the deepest muscle, and between, we would say, between the muscle and this muscle, of course, and tendons of flexors is the space. We defined it, or we name it, surgeons, they name it Paron's space, which contains synovial sheath of the tendons, and this could be affected by infection. So if infection spreads out, so then usually in the Paron's space. No good. The other structures within the wall of the muscles, within the wall of the muscles run the arteries. So we have to just mention that there is the radial artery plus veins, and on the other side ulnar artery and veins. So quickly we could say that these arteries, the arteries plus branches, definitely. Both of them are accompanied by by two veins, and they run together with some structures, and there are some important points. Concerning radial artery, don't forget on the pulsation against the radius, against the radius. We know radius in the distal 1/4, and then radial artery is used for the important, clinically important points. So maybe that we can call them again by green. Catheters, they are used in cardiosurgery, or for cardiosurgery. Then these vessels are used also for the arteriovenous interconnections, different types of interconnections, especially in hemodialysis, opposite dialysis, opposite hemodialysis. That's correct now, and that means between, because it's the arteriovenous, must be artery between the radial artery and the cephalic vein. That's it. Fine. And concerning ulnar nerve is more superficial than especially in distal part than the radial artery. Then is accompanied by the ulnar nerve in the distal ulnar nerve in distal part of the whole region, and again is also used for the catheters for cardiosurgery. Good. This is anterior, and then is posterior region, posterior antebrachial region. So they are in subcutaneous are superficial. Superficial, that means subcutaneous or cutaneous nerves, nerves on radial, mainly radial, and also, no, this is sufficient radial. Then there are two, then fascia, definitely, follows fascia. We will remember fascia antebrachy, and then two layers of muscles, many extensors, but also muscles of the thumb, little finger, etc. Different. Okay, interosseous, and then don't forget the deep are interosseous on the membrane, on the membrane interosseous nerves plus arteries plus veins on the membrana, on the membrane. That's it. Sufficient. So this was the brachy region. I mean that this is sufficient for our description. No, and then follows the carpal region. Concerning the carpal region, this is the area which say that this is the regiocarpalis, carpal region, again anterior posterior. No, carpal region is region of the wrist, also wrist, and where is that? Just simply covers. The region covers the joints, the area of the joints of the wrist, of the wrist. That's it. No, the carpal region is maybe that we can start first of all with the diagram. Here you see the carpal region anteriorly, the anterior palmar region on the right hand. What we see is the fascia antebrachio. We know that fascia antebrachii, the thickened fascia, forms the palmar aponeurosis. We mentioned long tendon of the palmaris longus, which is usually attached to the palmar aponeurosis. Then in the hand we see the thenar and hypothenar muscles. There are three. Then on the radial side or lateral side, follow the radial artery plus two veins are not seen. Then flexor carpi radialis, flexor pollicis longus. On the medial side is the medial nerve running separately, and then the flexor digitorum superficialis and profundus. Logically, medially around two structures together. That means radially, laterally ulnar artery, medially ulnar nerve. And most medial is the flexor carpi ulnaris. We have discussed that. No, and this muscle is attached to the pisiform bone, and then between the hamulus and pisiform bone covered by the pisohemate ligament runs these both structures. Here I've drawn just the nerve, but artery runs together, and we call it canal, Guyon's canal. This is a Guyon's canal or canalis nervi ulnaris, through which passes the artery and the vein. And another diagram, it's not bad to see that Guyon's canal. Here we see ulnar nerve, ulnar artery. Here in this Guyon's canal, this is that canal, they divide into the deep branch, superficial branch, not only the nerve but also the artery, pisohemate, and here is the pisiform ligament, and there is a superficial ligamentum carpi palmare, a part of this aponeurosis, of the superficial fascia. Note please that the most medial muscle is abductor digiti minimi. Here on the right side, the most superficial, again, abductor. No, and concerning the vessels in the carpal region, we can follow the course of the radial artery and ulnar artery. We remember that both of them send small branches forming the carpal palmar branches, some palmar arteries forming the rete articulare palmare again. The radial artery and palmar artery and ulnar artery, they form the superficial palmar arch. More blood receives by the thicker branch of the ulnar artery, while the radial artery forms the deep, profound palmar arch. Is arcus palmaris profundus. Main source comes from the radial artery, less from the ramus profundus artery ulnaris. No, and at the centralized medial nerve, together with the ulnar artery, ulnar nerve, together with the radial artery, just superficial branch of the nerve, but is seen on the lateral and dorsal side. No, carpal region. Briefly, we start immediately with the anterior. So the anterior carpal region. So we have seen many diagrams. I mean that we could start with the skin. Here is the relatively thin skin plus transverse grooves, Latin linea rascetta, not bad to know, linea rascetta. Then subcutis with the nerves, plus subcutis plus fascia, plus superficial fascia or fascia antebrachii, because it descends from antebrachium. Then important for us is the position of tendons and arteries, because ulnar and radial artery, as we have seen, are typical. Then follows the carpal tunnel, because they form the tendons. First of all, we have to say that carpal tunnel, we know the tunnel. We know the carpal tunnel, definitely. Carpal tunnel, maybe that the best would be either this diagram. Moment, please, moment. Here we see the section, but it's not section through carpal tunnel, it's a section through the mid of palm. But doesn't matter what we will see, the thenar, hypothenar, and mid-palmar space. The mid-palmar space contains not only the branches of the arteries, as we said, but also 1, 2, 3, 4 must be for tendons of the flexors, superficial deep flexors with the lumbricals, etc., and also the branches of the arteries and nerves. And also we see the interosseous space. So this is the mid-palmar space, thenar, hypothenar, and interosseous space. Maybe that more illustrative would be that diagram. I'm sure that I've also sent it to you in winter term. Again, we see the thenar, hypothenar, then ulnar artery on the surface. Then here we have the superficial palmar arch, which is situated between the palmar aponeurosis and then synovial sheath of the flexor, superficial and deep. On the lateral or on the radial side lies also the medial nerve. This runs together with the tendons into the carpal tunnel, although this is section in palmar manus. And then follows the deep palmar arch, which lies between the flexors, tendons or flexors, and then the interosseous space or interosseous area covered by the fascia and then covering the bones. So we see the position, very important position, the structures in this area. No, so carpal tunnel is bounded, as we said. Here we could say that it has the floor. Floor are the carpal bones, carpal bones, and roof is formed by the flexor retinaculum. Flexor retinaculum is attached to 4 bones. We know them, so running transversally, and into the canal pass the tendons of flexor. So then into the canal run the tendons of flexors, right? Tendons of flexors, medial nerve, and medial nerve, if compressed, so I would say compression, and we know the reasons why we speak about the compression. This is compression of the nerve caused by the either arthrotic changes of the bones, narrowing the canal, or it could be also edema or edema just without O. This is the classical Latin, modern terms, edema, or infection also could be of the orso, and so on. More reasons, or also thicker tissue, connective tissue around the vaginal sinuous sheath. Doesn't matter. So this leads to the syndrome of the carpal tunnel. No, and this syndrome of carpal tunnel shows the typical symptoms of the compression of the medial nerve. So this was already described. We can add also immediately Guyon's canal. Why not Guyon's canal? Guyon's canal. Nothing else, just to say that we have here that the flexor retinaculum, and Guyon's canal will be the same, medial lateral. Here you see the pisiform bone. Here is the hamulus of hamate, like that, pisohamate ligament, etc., etc. So the pisiform bone. Yes, there is the lamina, or we could see even the ligament, pisohamate ligament. So, and then the muscles definitely. Here is the flexor carpi ulnaris. Here is the abductor digiti minimi, etc. Here is descending the aponeurosis palmaris and the palmaris longus. Not necessary, this would be more superficial, no need. But here we have the ligament. Important for us is not a detailed description, but we can say just muscles of hypothenar, because this is just sufficient for us. No, and then drawing using red, drawing the course of the artery which runs here, passing through canal, dividing into the superficial and deep, superficial and deep branch. This is that one, deep branch. So this is also that one which forms the palmar arch. But I will draw just this one, superficial and deep. So the artery runs like that, and on the medial side runs or descends the nerve, which does the same, superficial and deep. You see, that's it. So here at this level, we see the Guyon's canal done. And we could say that sometimes also in Guyon's canal could be described the compression of the ulnar nerve. No, and this is the same as compression of the ulnar nerve in the proximal areas. Finished. Again, just please add claw hand. Fine. That's it. Carpal region. I mean that this is sufficient. We describe the flexor retinaculum, retinaculum musculorum, medial nerve retinaculum, extensorum dorsale. No, on the dorsal side, are 7, must be 7 carpal region, 7A, anterior 7A, and then we have also 7B, because it must be just few words. 7B is the dorsal posterior, so we call it posterior carpal region, posterior carpal region. No, in posterior carpal region, we speak about the extensor retinaculum, because this was ventrale dorsally. So dorsally is the extensor. No, first of all, we have to mention that there is a thin skin. Subcutis contains, it will dissect it, subcutis contains the superficial branch of radial nerve. Then follows the fascia, retinaculum, and retinaculum extensorum, the same, retinaculum sorum. Retinaculum is a thickened portion of the fascia. This is the same as in the ventral side. And under the retinaculum extensorum run also the tendons, the same as in the ventral side. Under this retinaculum descend or run the tendons and synovial sheath, which are separated. You see, synovial sheath separated by some connective tissue, by connective tissue. So this is thin, but this is important for when we compare it with the palmar side. So this is important for spread of infection. So we could say that spread infection doesn't affect the neighboring spread of infection alongside one of the tendons doesn't affect the neighboring tendons. That's it. So good. Carpal region, no? And then follows, when we are in the carpal region, we could start with fovea radialis. Why not? As number 8, we go to the end, foveola radialis. We already described foveola radialis in winter, so we will not draw any complicated diagram, definitely not. Just looking at the drawing, I've drawn it based on the reconstruction of the skeleton of the hand. Very simply, foveola radialis is bounded medially by the extensor pollicis longus, laterally by the brother of this one, extensor pollicis brevis, and on the border lies the abductor pollicis longus, abductor extensor. You see the attachments. And between them is the triangular space in which we see this descending radial artery. We know that radial artery passes obliquely, forming the dorsal carpal and metacarpal arteries, then passes into the hand, passing through or perforating the interosseous primus, dorsal muscle number 1, of course, forming or sending also digital dorsal artery, and then this branch supplies the supplies also the thenar and also the deep palmar arch. The second structure is the cephalic vein forming here the main trunk or main part, and then here we see the branches of the superficial radial nerve, so nervus radialis superficialis. So I think that fovea radialis simply is formed by the one muscle, second one, third one. So we have all, then the artery which passes obliquely like that and divides in the other branches, so radial artery. Then I'm not drawing accompanying veins must run together, but here runs the cephalic vein, no, and finally the nerve, the ramus superficialis nervalis. That's it. So if we would color the muscles by brown color, we can see all these three, and in green color we see the tendons. That one must be long, this is shorter, that one is also longer, and that one is shorter, yes. And we could label them, that means here we have that extensor pollicis longus, then that one is extensor pollicis brevis, and then that one, the last one, is the abductor pollicis, of course, must be also pollicis longus, because there is also brevis, and what we see is the radial artery, cephalic vein, no, and finally the superficial branch of radial nerve. That's it. No, it's well known also in the surgical terminology as a fossa tabatieri, as an anatomical, or also anatomical snuff box. No, fine. So I mean that this is sorry, must be better handwriting when we go to the end. must be standard writing. Sufficient. This was number 8, and number 9 is palma manus, complicated, very important area, region. Palma manus is and we could see palma manus. No, why not? In this photo, showing you the photo of this dissected area, looking at the abductor digiti minimi, most medial ulnar, then flexor digiti minimi, brevis, and then here between them is opponents. Then you see here the ulnar artery plus 2 veins with the nerve, ulnar nerve. They run together, of course, it's not completely separated. Then you see the medial nerve. Here is the medial nerve. Then tendons of the flexors. In the deeper, this is a superficial one. The deeper tendons. To deeper tendons are attached to lumbricals. Here you see also branches of the medial nerve. On the thenar side, we see abductor pollicis brevis. Then below that lies opponents, that flexor pollicis brevis, and the deepest one is the adductor, innervated by the ulnar nerve. No, palma manus quickly. Palma manus is also called regio palmaris. Why not regio palmaris? The skin is relatively thick. Píšeme skin is thick, with the exception of thenar. Thenar has relatively thin. Thenar, I would say thenar has thin skin, covered by thin skin, you can put. These eminences, and which are thenar, then hypothenar. Thenar, no.
Sir?
Not to mention 4 muscles. Hypothenar, 3 muscles. And we know that this is the abductor, adductor, flexor, and opponents, just abbreviations. And hypothenar has 3 muscles, which is abductor, flexor, and opponents, opponents. Fine. The important structure is also palmar aponeurosis. We know that palmar aponeurosis is thickened fascia. Palmar aponeurosis runs longitudinally, has also transversally passing fibers. The aponeurosis, or 2 aponeurosis attach the tendon plus tendon of palmaris longus, that's it. No, and finally, then at the center lies the central or mid, we call it also not only central but also mid-palmar space, and in the mid-palmar space are the structures found in the mid-palmar space. And it's not bad to know the positions. I try to simplify, just like a block drawing. First of all, we are looking in the hand, like that, in the hand. Here is the palmar aponeurosis. Okay, palmar aponeurosis, first one. Then follows the arcus palmaris superficialis. So this is the superficial. We call it simply superficial palmar arch. So here we have the superficial palmar arch like that. So, and the name superficial palmar arch. On the, this is the cross section, I would say cross section, definitely in the mid palmar space. No, then follows the group of the vaginae synoviales, synovial sheath. This is like that, synovial sheath. Okay, where you can identify the tendons of the muscles. So we could add that this is the tendons of flexors plus synovial sheaths. Of course, detailed description means that we have to draw also the bellies of the lumbricals. Then follows the deep palmar arch, as we see. So again, name, deep palmar arch. Good. And then follows again the fascia, palmar, interosseous fascia, and then follow also the bone. So that's why I just add so the mid-carpal, or no, not mid, these are definitely metacarpals. In the metacarpals plus muscles plus interosseous muscles. We remember that interosseous muscles are 3 palmar, they are adductors, and 4 dorsal abductors from the 3rd finger. So I mean that this is not bad to see, also the mid palmar space how it's arranged, and we know exactly the position of the palmar arches. And then the same is with the nerves. We know that there are two nerves. Nerves are two in number. So we know the vessels and nerves is the ulnar nerve. We know that ulnar nerve innervates the hypothenar plus deep belly of the flexor pollicis brevis and the whole adductor with two heads, ulnar and median. So we know the position of the nerves, how they run, how they supply. No, and there is also one clinical important point and term. This is the Dupuytren contracture. Dupuytren, French name, surgeon, contracture of not of the tendons, but of palmar fascia. No, palmar fascia, that means the also aponeurosis, definitely, because aponeurosis is part of the fascia, or thickened part of fascia. And we don't exactly the etiology. So etiology, the reason is not well known. This is fact. It's not well known. But palmar fascia aponeurosis is caused by what causes? We don't know exactly the etiology, but it causes the shortening of fascia, which leads to fact that fourth and fifth fingers, which are inflection are if they are inflection, if they are bent in palm, so not inflection, I have to add in extension. That's it. In extension, fingers. So if the fascia is shorter, shortening of fascia leads to the fact that fourth and fifth fingers, if they are in inflection, in extension, so in extension, remain bent in palm. So they are like when we look at the fascia. So then in the extension we try to extend, but fourth and fifth finger remain bent. See, they remain. This is important. Bent in, but remain bent. Right. And the fact is that another fact is that is not the tendons are shortened. So tendons of flexors are not involved in the shortening. No, this is important information. So I mean that it could be also all to the palma and the very last information is this was number 9. Yes, so name A, so number 9 B, and this is the dorsum manus, or also called regio dorsalis manus. Manus, not complicated, because in dorsum manus is continuous with the carpal dorsal region, so there are not so many structures. We could say that it lies over the metacarpals. We could say metacarpals, over the metacarpals. The dorsum manus is thin skin. We can look at the thin skin and we see the position of the tendons and also rete venosum. In subcutis we see the rete venosum, dorsale manus, also sometimes used for injections, not just injections, because we are speaking about rete venosum. This is the dorsal venous network. Then follows the extensor, part of the extensor retinaculum, which covers the tendons, and it's the same, the tendons with their synovial sheath, tendons and synovial sheath, part of them definitely of the extensors, not only extensors, mainly extensors, because we said, you remember, that they are also must be muscles of the little finger and index. You see that they are not only extensors, but in general there's also abductor, etc. of extensors, mainly. If I will write just extensors and someone say, oh, you have mentioned, you forgot, it's not correct. Extensors with separate sheath. Then deeper are the dorsal metacarpal arteries. Metacarpal, the same will be metatarsal on the foot, metacarpal arteries. No, and then dorsal interossei muscles. So this is relatively easy. Extensor retinaculum, and this could be also dorsum manus. Dorsum manus is not so complicated. In fact, the interossei muscles are innervated by ulnar nerve. We know it, ulnar nerve. Superficial, I haven't mentioned superficial nerves, but this is again the same as we said, ramo superficialis nervi radialis. You see, this is that one. Fine. I mean that this could be all. We did the best for the short review. As you see, it's not easy to do everything in a short time, to describe the regions, to forget minimum, to say maximum. But in the same way, we have to do the same for the lower extremity in the next week, and then we will follow with the trunk. After this block of topographic anatomy or review of topographic anatomy, we will start with the neuroanatomy. I would like to thank you for your attention if you attended, and hopefully that everything was under our control. Wishing you a good start into the studies in very complicated times. What to do? We have to try to do best. Thank you and see you again.